So good morning, everybody. I'm Neil Kalman, chair of the department here of Family Medicine and Community Health. And it's my pleasure this morning to have an insider be able to give grand rounds. So one day I was sitting in my office and the phone rang. This was right after we started the department, and we were trying to think about what we were going to do in terms of research leadership. And Dr. Crump was on the phone, and he said, well, thinking about coming to New York and whatever, and I hung up the phone after speaking to him for a little bit, and I said, oh my God, it's like sometimes things just like happen, and we met him and we were thrilled at the possibility of recruiting him from his previous position at Stanford, where he was the director of the Center for Primary Care Research. And it was our good fortune that one day he woke up and decided he'd had enough of California, that the wildfires and the potential of earthquakes was just too much to bear, and that he needed to come to New York. And it's been our good fortune ever since to have him really be the anchor, working with all of us faculty, residents, and students, and helping to mentor us in research. He has a partnership with researchers at Lund University in Sweden, where he has researched life course epidemiology. And my understanding from him is that in Sweden, they keep track of everything from birth to death. And so you can sort of track issues and relationships that we just don't have the ability to do here. He's been studying early life risk factors for cancer, physical fitness, cardiovascular disease, and adult health outcomes related to preterm birth, and the risk of suicidal behavior caused by alcohol and drug abuse. He conducts health disparities research here with us at the Institute for Family Health, and also provides care at the Family Health Center of Harlem. And so we're thrilled this morning to be able to have Casey Crump do grand rounds and tell us about his work. Thanks, Casey.
Thank you all for coming. Good morning. I'm delighted to be here and share some recent work toward a better understanding and working toward a life course approach to chronic disease risks. First, just a brief overview of what I'll be talking about this morning. I'm going to share some evidence for early life origins for chronic disease across the life course. I'm going to share some recent findings on this from my own work from large cohort studies of adult outcomes of preterm birth that have contributed to this area. And then I'll talk a little bit about implications for patient care and family medicine in particular, and also some implications for health disparities. In the field of psychiatry, it's been well known for way over a century and probably a lot longer that early life experiences have long-term effects and can manifest as disorders in adulthood. So if you were to visit a psychiatrist, you would probably expect at some point to be asked questions about your childhood. Even in the general public, this is so commonly known, I think it's somewhat taken for granted. However, how about in the field of medicine? When patients come to see their doctor, are they typically asked questions about the early part of their life? Do they expect to be asked such questions? I think generally not. There may be a few exceptions to that here and there, but overall this whole paradigm that is so well established and even somewhat foundational in psychiatry is not well established at all or common in the practice of medicine. So the question I'd like us to think about a bit this morning is, should it be? That's sort of the big question I'd like us to ponder a little bit during the course of this talk. The evidence that this might be the case has emerged relatively recently. In 1986, David Barker, a researcher in the UK, published a key paper in which he noted that the geographic distribution of heart disease in England and Wales paralleled earlier differences in infant mortality. And this was a little paradoxical at first, because the overall rates of those conditions in the UK overall were actually moving in opposite directions. Heart disease was becoming more common, while infant mortality was becoming less common. But when he looked in individual towns and counties, they were actually correlated. So it caused him to wonder and hypothesize that early life adversity around the time of birth might actually be causally related to the onset of heart disease later in life. And it turns out that that geographical pattern that he first noted was indeed later supported by individual level data and led to the development of the so-called developmental origins of health and disease theory. So I'd like to say a little bit more about that theory. Our usual conventional understanding of chronic diseases is that they're the result of unhealthy lifestyle plus genetics. The developmental origins theory recognizes that those are important, but they are incomplete. They are inadequate to explain chronic disease risks. In addition, there are intrauterine exposures, such as fetal undernutrition, for example, that may permanently alter the structure, function, and metabolism of various organ systems, resulting in what is sometimes called programming for the later onset of cardiometabolic disorders. And this sometimes happens, at least partly, through epigenetic pathways, alterations of genes that affect gene expression. Here's a brief schematic that shows how that might play out over the life course. There are prenatal factors, such as nutritional factors, placental insufficiency, others related to preterm birth that I'll talk about a little later, that result in altered structure and function and metabolism, partly through epigenetic pathways, and these are further modified or influenced by other factors in childhood and later in life that lead to the development of risk factors for chronic diseases like cardiovascular disease and an increased risk for developing these conditions later in life. So these very early factors around the perinatal period may have long-lasting effects that may emerge as chronic disease later in adulthood. The World Health Organization has recently recognized the importance of this, of understanding these long-term approaches for understanding chronic risk across the life course. The earliest stages of life set the tone for the whole of the lifespan, and they recently declared that a life course approach to health is essential for achieving global population health goals. The earliest work in this area, including the work by David Barker, whom I mentioned a moment ago, focused on birth weight. This is because that's has often been the most frequently recorded birth information that's the most available. And he found that low birth weight was linked with higher risk of heart disease and mortality 50 years later. However, birth weight is a composite measure that's affected both by fetal growth as well as the timing of delivery, so it's a mixture of these effects. More recent evidence has suggested that preterm birth in particular may be important for future outcomes because it interrupts the development of all fetal organs, which with differential effects depending on the timing of delivery. It's the leading cause of perinatal mortality in the US and worldwide. So this evidence has suggested that developmental programming on the background of preterm birth may be particularly important for future outcomes. So there's been a bit of a shift in research focus on understanding the potential long-term impacts of preterm birth across the lifespan. So I want to say a little bit more about preterm birth and its potential long-term impacts. Preterm birth is defined as less than 37 completed weeks of gestation. The worldwide prevalence is 11% of all births, or 15 million births per year worldwide. The prevalence in the US is almost as high, 10% of all births, or 400,000 births in this country every year occur preterm. The most important advances in the treatment of preterm birth occurred in the 1970s and 80s with mechanical ventilation, surfactant use, different therapies used to prevent or treat respiratory distress syndrome, which resulted in dramatic improvements in survival. And as a result, over 95% of people born preterm now survive into adulthood. So it's the first time in history that very large numbers of people born prematurely are surviving into adulthood. So the question is, what happens to these people across the lifespan? What is their health experience like? Their long-term outcomes are unclear but increasingly important. I mentioned that the prevalence of preterm birth in the US is nearly as high as the worldwide prevalence. This map shows prevalences by different countries, and you can see that the US has similar rates of preterm birth as much of Africa and South Asia, which have the highest rates in the world. Preterm birth also ranks very high among the global causes of years of life lost. It ranked 7th recently on a list of such causes after ischemic heart disease, other stroke, and other common infections. So the public health consequences are enormous of a preterm birth. Over the past 30 years or so, preterm birth increased in the US until it just recently stabilized over the past decade. But in a recent decade, there was a dramatic and unprecedented shift in gestational ages in this country. The historic norm the historic average of a 40-week gestation actually shifted to an average of 39 weeks. This was due to many different factors, including changes in obesity and diabetes, which are among risk factors for preterm birth, also a high use of C-sections in this country. But as a result, this dramatic shift happened that was unprecedented, this whole bell-shaped curve shifting to the left toward earlier gestational ages. This graph shows the number of adults living in the US who were born prematurely. I mentioned that the most important breakthroughs in treatment of preterm birth happened in the 70s and around 1980. I've indicated here when those first were introduced. But prior to that time, the number of adults who were born preterm was growing at about the same rate as the overall US adult population. But starting in the 1980s and 90s, after those treatment advances, this survival into adulthood dramatically improved. And so, as a result, it's the first time that very large numbers of people born preterm are surviving into adulthood. Clinicians will increasingly encounter people born prematurely among their adult patients. So the question again is, what happens to these people? We'll talk about that in just a moment. First, a quick note about gestational age terminology. I mentioned that preterm birth is less than 37 weeks of gestation. That includes this group in red called late preterm, 34 to 36 weeks, as well as all of the gestational ages to the left of that on this graph. Another group that's of particular interest is called early term, 37 or 38 weeks, which is shown here in purple. This group is of special interest also because, like preterm birth, it also has been associated with higher infant mortality and mortality in early childhood. So I want to say just a little bit more next about early term birth. Term birth is defined as 37 to 41 weeks of gestation. Most people are familiar with that terminology. Even the general public is quite familiar with the term of term birth or full term. But where did that come from? Where did that definition originate? It actually was arbitrarily defined almost 50 years ago. We've been using that definition ever since then. However, starting in the 1990s, early term birth was found to be associated with increased infant mortality compared to later term birth. This is potentially has big public health implications and importance because of how common early term birth is. Almost a quarter of all births in this country occur in that time period. So an enormous number of births. This makes it more than twice as common as preterm birth. And the long-term mortality beyond childhood in this group is unclear. So this is also a group of particular interest. So the questions I'd like us to consider are what happens to preterm and early term survivors in adulthood and across the lifespan. There are several challenges in studying this. First of all, you need very large birth cohorts with several decades of follow-up, following people from birth well into adulthood. That's extremely hard to do. You ideally need to be able to capture multiple health outcomes across the life course, and you want minimum loss to follow up. All of that's a really tall order. To my knowledge, the data for examining this actually do not exist in the US because of our fragmented health system and the difficulties of following large numbers of people over decades of time is just not feasible. And these data are also scarcely available elsewhere in the world. However, I did find one place where this could be studied, thanks to the Scandinavian universal healthcare, and particularly in Sweden. Sweden has nearly 100% complete registry data on health outcomes and demographic information for their entire population of 10 million people. Their universal health system facilitates the collection of these data for everyone nationwide. Generalizability of these data to the US is actually good for most outcomes, and it's increased due to high rates of immigration in Sweden. Sweden has a much more diverse population than many people realize. In fact, about 26% of the population consists of first or second generation immigrants who have come from, many come from Asia, Africa, and South America. So this has improved generalizability to the US, and these data are very rich data that enable tests of hypotheses that have similar mechanisms as the US, but are not able to be studied here. My collaboration in Sweden is with Lund University, which is located right at the southern tip of Sweden, here in the city of Malmö, just across a bridge from Copenhagen, Denmark. And located in Lund University is the Center for Primary Healthcare Research, where we have a research partnership. This center may be the largest primary care research center in Europe, or at least one of the largest in Europe. It's directed by Dr. Christina Sundquist and Dr. Jan Sundquist, shown here, who are both family physicians in Sweden and epidemiologists. Family medicine is very well established and common in Sweden, and both of the Sundquists have adjunct faculty positions here in our Department of Family Medicine at Mount Sinai. I want to give you a sense of just the kinds of data that are available in Sweden that are listed here. They have complete demographic information for over 12 million people, both living and deceased, since 1932. They have extensive multi-generation data that enables lots of family-based studies, complete information on immigration dates and countries of origin, birth information for over 4 million children since 1973, all hospital and outpatient diagnoses nationwide from these dates. They have a military conscription registry with physical and psychological exam data on over 2 million military conscripts over several decades of time, as well as nationwide death information, a cancer registry, nationwide pharmacy data on all medication prescriptions nationwide, and geographic information systems data on neighborhood level factors for over 9,000 neighborhoods in Sweden. And the important thing about these data is they are measured on the individual level, or that is separately for every single person in Sweden. And all of these data are mutually linkable, so you can imagine extremely rich data for assessing all kinds of important questions. There are very different public attitudes in Scandinavia about the use of these data. There are, on the one hand, privacy concerns and respect for people's privacy, but this is very much balanced with a belief in the ethical responsibility to use these kinds of data for the public good in understanding health and improving health. Better?
No,
okay.
You're too tall.
Okay, thank you. So I'd like to share just some brief highlights from one recent study that assesses some of these questions. Specifically, what are the long-term mortality outcomes of preterm and early-term birth? And then we'll talk about some of the implications for long-term patient care, the definition of term birth for the practice of medicine and family medicine in particular, and also health disparities. So briefly, I'll describe one of our recent studies. This included over 4 million live births from 1973 through 2015, with linkage of the birth data for these births to death data, which are over 99% complete for the population. The predictor was gestational age at birth, which was measured by last menstrual period in the 1970s, and then ultrasound estimation since then. And the outcomes were all-cause and cause-specific mortality through 2017, which was up to age 45 years. I mentioned earlier that the the most important breakthroughs in neonatal treatment happened in the 1970s and 80s. That's about the beginning of this birth cohort. So this 45 years of follow-up is actually the maximum follow-up that could be done for people who have received modern neonatal care. We use survival analysis with Cox regression to compute hazard ratios, which are measures of relative risk for the association between gestational age at birth and either all-cause or cause-specific mortality. And we adjusted for several other factors that are listed here, both perinatal and maternal potential confounders. And we assessed this in different intervals of attained age that are shown here among people who survived up to the beginning of that age range, just to assess mortality risk in different stages of life across this time span. This is the distribution of gestational ages in this cohort. Early term births in the upper left were 17.6% of the cohort. Preterm birth, shown in yellow, 5%, which is less than in the US. Post-term was not really a focus of this study, but was about 8%. And then the reference group, the comparison group, was the big group of full term on the right. And this is a summary of some of the main findings. These are adjusted hazard ratios and 95% confidence intervals for all-cause mortality among people born preterm or early term relative to full term in different intervals of attained age, which are shown in the leftmost column. And you can see first that people born preterm, preterm infants have a very high mortality risk in the first year of life, 17 times the risk of infants born full term. This declines a lot, but remains elevated, even a twofold increase in childhood. It continues to decline in adolescence and adulthood, but remains significantly elevated with hazard ratios of 1.4 and 1.3. So in other words, among people who survived up to age 30 years, people born preterm had a 30% increased risk of dying between ages 30 and 45 compared to people who were born preterm. So still a significantly increased risk that persists well into adulthood. Among people born early term, and keep in mind this is a group that is traditionally considered term births, but just the early part of that period, the first 2 weeks. And we found a similar pattern, but just smaller hazard ratios, but still a significantly elevated risk of mortality that persists into adulthood with hazard ratios in adulthood of 1.2. So this is a modestly increased risk of mortality, but still on a population level, given the vast numbers of births that occur early term, this is not a trivial increase. In this chart, all preterm births are sort of lumped together as one way of sort of summarizing some of the findings. But we also examined that stratified by different gestational ages, which I'll show you on the next graph. So here, this shows adjusted hazard ratios for mortality on the vertical axis by attained age on the horizontal axis, and by different groups of gestational age, which are shown in the legend there. Extremely preterm in red, very preterm in green, late preterm blue, and then early term, all of them relative to full term birth, which is in black. And I've shown you the first part of this graph first, because this is the part that was previously known. Those top lines, by the way, go to much higher relative risk in early childhood. That part is not shown on this graph. But it was already known that people born prematurely have increased mortality risk in infancy and early childhood, but that these decline over that period. And the conventional wisdom was that when people born prematurely make it through that period and survive that period, they generally do well, and their mortality risk and health risk may begin to approximate that of the general population. But only when we looked further into adulthood, we found that the rest of this looked like this. They don't actually continue to decline, or at least not by much. They stay persistently elevated well into adulthood, with twofold risks among those born extremely preterm that persist into adulthood, and very preterm, which is sometimes called moderately preterm, still about 1.5 or 50% increased mortality that persists into adulthood. Late preterm with around 1.2 or 1.3. and even early term, around 1.2 or 20% increased mortality that persists into adulthood. So all of those findings were for all-cause mortality. So what were the causes of this? And that is shown here. We found, this shows cause-specific mortality in adulthood for those born preterm or early term compared to full term. And we found that there were multiple different causes. The strongest association was with mortality attributed to congenital anomalies, which are mostly heart defects, which are more common among people born preterm or early term. However, these did not fully explain the mortality risks I showed before. Even when we excluded people with congenital anomalies, those mortality risks were not really significantly changed. We found multiple other causes, including endocrine-related mortality, which was primarily diabetes-related deaths, neurological causes, which were a number of conditions, including cerebral palsy and seizure disorders, respiratory-related mortality, which included many respiratory infections, cardiovascular-related mortality, which was a mixture of ischemic heart disease and various cardiomyopathies. In contrast, cancer, on the other hand, did not have an increased risk among those born preterm cancer mortality. And for early term birth, we found a similar pattern for all of these different causes, but lower hazard ratios, relative risks. I mentioned earlier that preterm birth interrupts the normal development of virtually all organ systems. So these findings are consistent with that. We're finding increased mortality from a number of different causes in adulthood. I also mentioned that these results were adjusted for different factors, such as maternal smoking, maternal age, various different potential confounders. What about the possibility, however, of other factors that we were unable to measure? What if there are genetic factors, for example, that predispose to both preterm birth and increased mortality risks? We were able to assess this using a somewhat innovative approach, comparing siblings who were born at different gestational ages. And so I wanted to briefly mention this. We had over 2 million sets of siblings who were compared. And this is one way of controlling for factors that are shared among siblings, including their shared genetics, including shared environmental factors that they might share growing up in the same household, even if those factors were not specifically measured by us, which was not possible. And we found in these analyses that the main findings were actually unchanged. For example, comparing preterm to full term, the adjusted hazard ratio for mortality in adulthood was about 1.3, which was the same as I reported before. So this showed that these findings were not explained by other shared familial factors that we were unable to measure that might predispose to both preterm birth and mortality, but instead they're likely from the direct effects of preterm birth on these future outcomes. So this analysis helped strengthen our results and show that they're likely from some independent effects related to preterm birth. I've shown some outcomes entirely related to mortality up to this point, but we've also tried to assess more comprehensively other outcomes in adulthood among people born prematurely, and some of those are listed here. Chronic kidney disease, ischemic heart disease, sleep-disordered breathing, which is mainly sleep apnea, hypertension, and type 1 and type 2 diabetes. All of these were assessed using nationwide diagnoses in Sweden, inpatient and outpatient. And I've just presented a brief summary of those. These are hazard ratios with 95% confidence intervals comparing people born preterm to full-term births. And you can see increased risks of these in adulthood for all of these outcomes with relative risks that are typically around 1.3 or 1.4, though for type 2 diabetes it was 1.6. So persons born prematurely had about a 60% increased risk of developing type 2 diabetes in adulthood, for example. So just to summarize some of those long-term outcomes, we found that preterm and early-term birth were associated with increased mortality, not just in infancy and childhood and adolescence, which was previously known, but persisting into early to mid-adulthood. And in adulthood, there were a variety of causes of this, including congenital anomalies, diabetes, neurological, respiratory, and cardiovascular diseases. And we also found that preterm birth was associated with multiple other chronic diseases in adulthood that I showed on the previous slide, with most relative risks in the 1.3 to 1.6 range. I mentioned earlier some of the strengths of these data that help overcome certain challenges, including the large size, the ability to adjust for different factors, and also the co-sibling analyses that are even able to control for shared familial factors that were not specifically measured. But I also want to mention a few limitations, including the fact that the extent to which these findings may be generalizable to later cohorts is unknown because of the fact that neonatal and pediatric care is still continuing to change over time. So people who are born prematurely today may or may not have similar outcomes that I've shown here. We will need to follow those people as later data become available. Also, preterm birth is, of course, very heterogeneous. There are many different underlying causes that are sometimes categorized into these broad categories of spontaneous and medically indicated preterm birth. These could have heterogeneous outcomes in adulthood, and that's one of the big questions that remains to be answered. In Sweden, these factors were not systematically measured before 1990, and therefore among people for whom we have the most follow-up into adulthood. So we have not yet assessed for that potential heterogeneity. And of course, these findings were limited to Sweden, a very high-income developed country. So this, of course, needs replication in other diverse populations whenever those data are possible. Some of these findings I just presented were just recently published. You're the first group to hear about many of them. They were just published in the last couple of months. A few years ago, there was also a trans NIH workshop on this topic that included some of the earlier work that led to these findings, as well as other work from around the world on this area. That there is a good recognition at the NIH about the public health importance for these long-term outcomes in the US as well as worldwide. These findings, I think, do have some important clinical implications. Just going back to the original question that I started with, all of these findings do suggest that this life course perspective is very relevant in patient care, and it helps put patients' health risks in a better context for understanding them across the lifespan. Not just their experiences in childhood, but even earlier in the perinatal period or preconception. These are very relevant even in adulthood. Some of these findings I just presented show specifically that preterm birth should be recognized as a chronic condition that needs long-term follow-up across the life course. This has definitely not typically been the case. Preterm birth has been regarded as a pediatric condition, but we need to begin recognizing it as a long-term condition that affects outcomes across the lifespan. And furthermore, it suggests that birth history ideally should be ascertained in patients of all ages that would allow us to take this life course approach. This is very challenging in the US due to our fragmented health system, but ideally this should be done at birth and become part of patients' permanent medical record. Health systems should at least work toward that goal. The findings I presented are new enough that they have not been incorporated into screening guidelines, but I anticipate that eventually they will, and preterm birth may be included as a risk factor that would trigger possibly earlier screening for diabetes or kidney disease or hypertension. And, but simply being aware of these long-term risks would allow patients and physicians to put patients' health in a better context. And it may also motivate, for example, healthier lifestyle changes to support long-term health and improve the health trajectory of these patients. I think there are also some implications for family medicine in particular. All of the evidence I've talked about, including the earlier work by David Barker and some of the other more recent findings I just showed, do suggest and support the need for a life course approach in clinical care. Family medicine is the ideal clinical discipline for a life course approach because family physicians see patients of all ages and across the lifespan. This is very interesting to me because these findings I've talked about are quite recent. The evidence that has supported some of David Barker's initial hypothesis that he presented in 1986 have emerged only in the last couple of decades, and other findings that I presented just in the past few years. But all of them suggest the importance of taking this life course approach in patient care for which family medicine is ideally suited. Or to put that another way around, if family medicine did not exist, based on all of these findings, we would want to create it. It fundamentally makes sense. I realize I'm preaching to the choir on that point, but family medicine is historically known for a highly contextualized approach to patient care, understanding patients in the context of their communities, their families, realizing the important influences these factors have on people's health and well-being. And the life course perspective is another fundamentally important dimension for understanding patients in context. And family medicine is ideally designed for incorporating that kind of approach. Just want to mention one other interesting implication of these findings. I mentioned the definition of term birth earlier. This was arbitrarily defined in 1970 by a European working group that coincidentally was working with Swedish data from the 1940s and 50s. And they defined term birth as 37 to 41 weeks. This was originally intended to denote a low-risk period of births using the best available data they had at that time. The definitions that we use are important because they affect clinical and public perceptions. There was one study, for example, that found that over 90% of US women consider it safe to deliver before 39 weeks, because after all, 38 and 37 weeks have typically been considered part of term birth. The long-term health sequelae, including the ones I presented here of early term birth, have supported a redefinition of full-term birth. And in fact, this has happened just in the past few years. The American College of Obstetrics and Gynecology did propose a redefinition of full-term birth as 39 to 41 weeks. And our findings would definitely support that because they show the long-term mortality risk and health risk that persists into adulthood in that early term group. One last question that I want us to consider, but I think it's a really important one, and that is, do the long-term effects of preterm birth that I've talked about in this presentation, do they cause or contribute to health disparities in the US across the life course? And one reason for suspecting that this may be the case is the fact that cardiovascular and other chronic disease disparities among adults in the US parallel similar disparities in preterm birth. And I'll show that on the next slide. This shows the prevalence of preterm birth in the blue bars with the key to that on the left axis, showing prevalence of preterm birth in different racial and ethnic groups, and cardiovascular disease mortality in the yellow bars with the key to that on the right axis. And you can see that these disparities across different racial and ethnic groups closely correspond to each other. These are data from the US on the population level, but we have also found on the individual level that preterm birth is associated with a higher risk of later heart disease, and I'll show that here. This is from a study just published about a week ago, so it's fresh off the press, but we found in the same Swedish cohort as before that preterm birth is associated with the emergence of ischemic heart disease risk in relatively early adulthood. On the vertical axis is adjusted hazard ratios for ischemic heart disease, and the horizontal axis attained age, and different gestational age groups shown with the different colored lines. But you can see among those born preterm compared to full term, which is the black line, relative risk of around 1.4 in early to mid adulthood of ischemic heart disease. So this shows that preterm birth is linked on an individual level to this early emergence of ischemic heart disease, which might also connect disparities in preterm birth that I showed before with disparities in heart disease. This is one example, by the way, of a question that could only be assessed in Sweden, but that has important implications for health in the US, and specifically about disparities. It causes us to hypothesize that there are early life origins for health disparities in US adults across the life course. There are a number of prior studies that have traced cardiovascular disease disparities back into childhood and adolescence, which may be due to racial ethnic differences in environmental stressors. For example, some studies have found subclinical atherosclerotic changes in adolescents that are more common in black teenagers compared to white teenagers, and that these are associated also with chronically elevated cortisol and inflammatory markers. So it has been speculated that there may be chronic stress in early life that may contribute to these health disparities in the US. We hypothesize that these may originate even earlier in the preconception and perinatal periods related to these disparities that exist in preterm birth and the associated health risks from those. So this is an important area that will ultimately need US studies to tease out the effects of these long-term effects of preterm birth on the development of disparities across the life course in the US. So that brings me just a few future directions for this work. First, additional follow-up will be needed to older ages. All of the work that I have followed these people up until the mid-40s, which I mentioned is the maximum follow-up currently possible for people who receive modern neonatal care. So that's, but it's unclear what these findings will look like at older ages. Some of our findings, I think, provide a cautionary note about extrapolating findings to older ages, because our findings already have sometimes been surprising and contrary to what was initially expected. These issues will also need to be assessed in later birth cohorts, which might have different long-term health experience due to the changes in neonatal pediatric care over time, and in other racially and ethnically diverse populations. And US studies will be needed to assess the effects on health disparities in adulthood. And hopefully, we're exploring ways to do that in New York and possibly even among the patients that we serve. I think that's a really important future direction. I want to acknowledge my collaborators whom I mentioned before in Sweden, Christina and Jan Sundquist, and also the funders of this work at NIH. And thank you for being here and listening. Thank you. I'd be happy to take any questions if there are any this morning.
Awesome.
Oh.
Thank you. There really is kind of this perspective of how we manage a woman's prenatal care really could have implications beyond just the birth experience, which is, I think, what sort of we focus on. If the baby is delivered safely, good APGARs, mother does well, that's it. So thank you for bringing this to our attention and the connection. One of the things I'm curious about is some of the implications on behavioral health conditions, and thinking about depression, anxiety, substance abuse. Have you thought about any of those conditions in terms of this sort of life course analysis? And the interesting thing of your connection early on with psychiatry is to think about the fact that those early life experiences could have implications for one's physical health in addition to their mental health?
Yeah, that's a great question. We have assessed that a little bit in some of our earlier work, and our work, as well as others in that area, have found increased risks of those kinds of conditions like depression and anxiety. We specifically used nationwide medication prescriptions for these conditions and found higher rates among those born preterm with a gradient for earlier gestational ages. So that there does seem to be other associations with psychiatric outcomes as well. But that's not our current focus, but it's a really important area, and we do find positive findings for that.
So I was struck by I think there was a slide where you showed the increased prevalence of diabetes at like 1.6 or something like that.
Yeah.
So the move of the gestational age, the bell-shaped graph, and as that sort of moved over, it struck me that was that if you look at the prevalence of diabetes and how it's really increased over time, mm-hmm. I'm wondering if those two things could be related, and if there would be a way of figuring out what percentage of the increase in prevalence of diabetes in the country might be explained by the shift in gestational age. Because we know that diabetes is increasing and nobody knows why, right? I mean, obesity has increased, but that doesn't explain it all. I wonder what percentage of that increase might be due to the fact that of the shift in gestational age. Could you is there a way to figure that out?
There probably is, but some of those changes you're referring to are specifically in the U.S., where I don't think the data likely exists to answer that definitively.
So there's no increase in prevalence of diabetes over time in Sweden, the same way there is in a lot of other countries? We don't know.
I don't have those numbers, but I suspect there is some increase. What we have found is that even when we adjust for maternal history of diabetes and family history, we find that these associations with preterm are independent of this.
Right.
And you're asking a great question about quantifying that further. So I think that's
to see what impact it have. It might be a major factor if given the whole shift of that curve, the way you showed it.
Exactly. Yeah.
This was amazing. Thank you. Really, really interesting and helpful. My question is, what this really highlights is that some of these preterm babies go on to develop lots of different medical conditions. Some of them don't. And my question is there anything in your data that would help us understand, are there factors that are protective in early experience or that in fact increase risk? I mean, one of the things I'm thinking of is breastfeeding, for instance. We know that certainly in the early days, in the 70s and 80s, when your data starts, babies in the NICU were not breastfed. And that has shifted over time a little bit. But there are many others. There's also a very big body of data that suggests that parents interact differently with preterm babies than they do with full-term babies.
Yeah.
So have you been able from your data to identify any of those factors that might help us to say, oh, you have a preterm baby, but here's something you could do that would mitigate the risk?
Yeah, those are wonderful suggestions. These data, as rich as they are, do not have some of those factors that you're mentioning, like breastfeeding, for example, or some of the other parental involvement. So we're not able to tease that out fully. There might be some smaller cohorts that might have more detailed information on those factors that would be really useful, I think, to study. Yeah.
Hi, good morning, everybody. It's my last grand round, so I'm feeling nostalgic. Thank you, Dr. Crump. I had just a quick question that I also wholeheartedly agree that family medicine is the ideal discipline to ask these questions, and I think we all can agree when we ask them, we unearth things that make a lot of sense for the present. However, asking questions about birth and childhood takes time and unearthed trauma, and you have to have the space and time to ask those questions. As I go out into the world of being an attending and realizing that primary care is dictated by these 15-minute visits and productivity is the focus, do you have any advice for us of how to keep this central to our work and how to make sure we don't miss these huge questions that do inform care and do inform how we can actually really help the patient?
Sure. Great. Thank you for that question.
Thank you.
Well, first of all, just for ascertaining birth history, I mentioned a little bit in the talk that ideally this should be done at birth, and it should become a permanent part of people's medical record. There are a lot of factors in the U.S. that make that very challenging because of the fragmented system that we have. But this ideally shouldn't fall onto the physician to do, but it should be recorded at birth and should be, or even linked from birth registries whenever that's possible. EPIC, as you know, has a birth history section. I think it is generally very underutilized, even for pediatric patients, not to mention beyond the pediatric period. But I would, for starters, I would encourage people as part of their annual assessments, to include that, at least at that patient contact, to complete that, and at least makes, considering those factors, it makes them possible if we kind of utilize that section a little bit more. I also mentioned these findings are so new that they haven't yet been incorporated into screening guidelines, but I anticipate that eventually they will be part of various guidelines that we will consider among other risk factors. Prematurity will be recognized as a long-term risk factor for some of these chronic conditions. I think a useful start is simply a better awareness among doctors as well as patients of the long-term implications. It could potentially, lead to more discussions about healthy lifestyle factors that could kind of support the health trajectory in these patients. These findings that I mentioned, they are undoubtedly modifiable by other factors across the life course that we're not able to assess. But with the background of prematurity, which is an underlying risk factor, it makes other healthy changes even more important. So it could possibly help motivate some of these changes in patients with this underlying risk factor. So hopefully a better awareness of these long-term effects could facilitate or lead to some of those conversations and health promotion in these patients.
So I have a question about the use of big data, big databases like this. So everybody's talking now, since we have electronic health records and we have, not only do we have electronic health records, but we have health information exchanges, so that data is being collected in huge quantities and stuff like that. So you have all of this Swedish data. How does one go about finding things that are not necessarily, that don't necessarily come from kind of gee, maybe this is related to this, but actually going into the data and finding associations that might be causations that nobody's even thought of? In other words, is there a way to just take all of this data from Sweden or from the things that we're collecting now and just kind of saying, check everything against everything else to see if there are associations that we might not even have thought of, or that might shed some light on some of these things? Because I mean, this is kind of groundbreaking, and there might be other groundbreaking things hidden in this data that people who eat something all get some crazy disease. Or I mean, what would you do with what can you do with big data to go fishing?
Well, we are usually not fishermen, exactly, but there are environmental-wide association studies which are kind of patterned after these gene environment wide association studies that can assess kind of across the board for all kinds of associations. We have not done that in our work. Undoubtedly, it would find lots of false positive or spurious findings that have to be that creates its own problems. But we usually focus on questions that we know will be of clinical and public health importance, regardless of the outcomes. And we haven't really done that kind of fishing type work with these data.
Another perspective, this is really how Sweden handles this data, but I could see a situation where if this becomes common, that this becomes basically a condition that would adversely affect your coverage. And so I'm wondering how Sweden has sort of handled this, and just, basically, puts you at if you have a slightly adverse birth outcome, what does that do to sort of your insurance coverage and those kinds of ethical issues that might come from making this information more well known?
Yeah, well, Sweden, as you may know, has universal health coverage, which is really unaffected by these kinds of issues. Everyone has access, and and so that really reduces lots of barriers, financially and so forth, and also different disparities in access to care. So that hasn't really developed as an issue there. And here it would have the same effect as many other, pre-existing conditions. So, yeah, thank you.
So this was our last grand rounds of this academic year, where we take off for July and August, and we'll see all of you and hopefully 100 other people starting in September when we make grand rounds mandatory for all of our residents. Thank you, and faculty.